Assalamualaikum warahmatullahi wabarakatuh and good morning to everyone. Fortunately, together with this Breakfast Half Morning, we are also celebrating our International Day of Older Person 2023. And today, this year, we are talking about human rights for older persons across generations. Okay, without further ado, I'll just continue with my talk today. Fall and Syncope Clinic in UM. So as what Dr. Amanda has been saying, that we have been running this fall clinic for the past almost 9 to 10 years, but the first 5 years were only research clinic where we select cases, and recent 5 years from 2018 and now we are receiving a lot of referrals from other units, especially from emergency medicine, from orthopedic clinics. We also receive referrals from the ENT, neurologists, and also our endocrine. This regards into autonomic function, autonomic dysfunction, or blood pressure drop, autonomic hypertension, and further on. So what is fall? It was unintentional coming to rest on the ground, and is due to multiple causes. It's not just one single cause that can lead to a fall, and majority of the fallers are aged more than 60 and above. So it becomes a very niche for our generation and something that is very important for us, because fall itself is a red flag. So any elderly person who fallen for the past within a year have tendency to higher mortality, up to 30% mortality within a year after a fall. That's why our direction take up this challenge to work with cardiologist unit to develop this fall and syncope clinic. So syncope is a transient of self-limiting loss of consciousness with subsequently complete recovery, which is spontaneous. So when you fall and you had sudden blackout, that is when we start considering whether this is a syncopal attack rather than just a fall. It can be due to cerebral hypoperfusion. Thus, there is some element of forgetfulness during the fall, so they are not sure what happened. They can't really tell you whether they are asleep or they are tripped, whether they hit something, but they could actually just feel that they were on the floor and having some injuries. Perry et al. Say witness loss of consciousness during induced one of the study by Perry et al. Have able to show that there is a loss of consciousness during a clinical laboratory test. So when in a clinical laboratory, you make a situation where somebody fall down, but when you ask the person again whether they did fall down, they deny. So this is where we kind of became very aware there's these things where we call syncopal fall, where the fall can be very injurious, but the participants or the patients themselves are not sure whether they are falling down or not. Causes of fall can be intrinsic and extrinsic causes, and this is very, very common in our elderly. There are some poor gait and reflexes, visual impairment, hearing impairment. These all the psychological, the physiological change as you grow older that it can't be denied, but can be treated and managed early on. And this is something that we want to champion and encourage our elderly population. Chronic diseases and medications is something that is also very common. Extrinsic factors that we ourselves and other physicians could also take charge, such as floors, speed level, lighting, cultures, and all this we actually manage with the help of the physiotherapists and functional therapists to ensure that these are not happening in our elderly population, houses or places. Okay. So what we have here is the study that we've done in 2016. As I said to you and I told you just now, we were doing this study research clinic at first. So from our study, we managed to publish a paper on what are the causes of falls in our population, specifically Klang Valley area. And when we did the study about almost 1,500 participants, we found that 60% of them falls are contributed by gait and balance disorder, but also majority of them falls due to orthostatic hypotension. Means their blood pressure drop, and they are not sure whether they have fallen or is it a syncopal attack. Other common causes such as home hazard, which is clutters, visual impairment, vasovagal syncope, poor foot wear, also arthritis, foot problems, and here on. And fourth is one of the quite few multifactorial causes that can lead to fall in our elderly population. This is our flow chart that we've been using in the emergency side, where you could see anyone that present at fall clinic would need to go through detailed history taking. They should have at least basic gait assessment. They should be done cognitive assessment, baseline blood investigation to ensure they are not dehydrated or there's any other viral or infection carrying on at the same time. Simple ECG. They should be referred to vision and hearing impairment for vision and hearing assessment, and if possible, home assessment, which has been a bit difficult, I would say, for the past couple of years due to COVID. And if the falls are severe, injurious falls, which means that there's involvement of fracture or bruising over the head and the face area, what it tells us is also means that it's higher tendency is it to be a syncopal fall rather than just a fall itself. If it's occurring more than once, which is twice in a year, we consider it as a very significant fall that further investigation and assessment should be done, and referring to the fall specialist clinic are necessary. This is simple. I think every physician or although us as doctors knows that when somebody fall or occur some event, the history should start off what happened prior to event, the precipitating factor, what happened during the event itself, and what happened after the event. In taking history for someone who having fall, it becomes very, very important because you are trying to differentiate multiple causes of fall. So you are trying to first ensure whether this fall is something that you should take seriously, or you could allow patient to go home. Because you see sometimes sleep or trip could be something that we might not be able to cater them in the ward unless they have complication due to the fall. But sometimes you have to also get further history such as patient are being unwell prior to this, whether they have memory issues, whether the fall event occurs with sudden loss of consciousness, blackouts, or palpitation that could suggest cardiovascular involvement also. And you want to see what happened after. Whether there's fitted drooling saliva or incontinence that can suggest epilepsy, whether there's severe bruise, head injury or fracture that suggests a very injurious or heavy fall that would probably need us to investigate further on. So let's just take things a little bit lighter on one of the common cases that we see in our clinic or in our ward. It's about Madam Emmy. She's 76 years old. She presented with recurrent falls. So when you see recurrent falls, means falls have occurred more than once in a year. She said she suddenly lost her balance, and the first fall occurred when her 4-year-old grandson jumped on her and she was trying to catch him. Another episode occurs while she was cleaning her living room and felt her clothes caught to the side of the chair. So what you can see here is she wasn't really convinced, but she feels that's probably the reason why she fall down. And in elderly population, especially in our generation, they tend to minimize the fall. And I tend to dig a little bit more as like amnesia, forgetful of falls, and they tend to forget not so good things. So they tend to like, oh, I've fallen like once or only one time, or the other wasn't that severe. So they try to minimize the event itself. So proper history taking is very important. You look at their medical history, she obviously have risk of falling down because she have bilateral knee osteoarthritis. She has kyphosis, osteoporosis. She have very poor gait and mobility. So you could, I mean, at the end of the day, you could just say it's because of her poor gait. She denied palpitation or dizziness or any loss of consciousness during the event. She was aware of her falling down and felt that her reflexes were slow. Okay, probably she got hypertension, osteoporosis, history of left hip replacement, June 2019. Then it would suggest that she has been falling not just twice this year, but probably more frequently than she actually telling you. You have to look through in detail in terms of blood pressure medication. She's on amlodipine, simvastatin, calcium, quite a good medication in terms of osteoporosis management. Stays with her son, daughter, and grandson. Still driving, although it's short distance, cooking and grocery shopping. So you know that this patient, although she's 76, she's quite independent on her own. So you want to keep her and you want to prevent her from having needs to falling down, another fracture, or dependent on others. So other, so you can see like kyphosis and type up and go. You do time and go to see whether they are walking distance more than 15 seconds. That suggests that she's having a poor gait. Hand grip is quite poor. But her MMSE is quite good, 23 over 30, 28 over 30. So management plan, due to all the risk factors such as osteoarthritis and osteoporosis, you probably want to refer to physiotherapists to help in terms of their gait and posture training. Encourage limb strengthening exercise. So when you talk about exercise, it's not just having this cardio exercise, ensure that you jog and so you sweat. In elderly population, we encourage them to lift weight. Yes, lift weight. We want them to lift weight so that they have improved their limb and improve their muscle strength. Of course, it's not 20, 30 kg, maybe only like 1, 2, will be sufficient enough. Management of the pain for the OA, home assessment and home safety in terms of purpose, and blood pressure monitoring. Sometimes in elderly population, they have taking this antihypertensive for many, many years, and they tend to not monitor their blood pressure, just taking over the counter, which is very, very common. And you will see that sometimes their blood pressure could go lower than expected. For her specifically, fall diary is important, and you probably want to refer her to ophthalmologist, ENT, and further on. So what do we do as a fall clinic specialist? This patient would be referred to us, especially because they have hypertension issue. And the blood pressure, they are not sure whether it's amlodipine sufficient, a bit too much, or under, a bit too much, because sometimes they have overtreated hypertension leading them to hypotension. Okay, what we do here in the fall clinic. For the evaluation, they send could be 24-hour portal, 24 for our BP monitoring. Although we are not, we don't think it's sufficient enough because only a day monitoring will not be able to monitor what actually happened throughout throughout the days of our patient. Because you can see even for atrial fibrillation or ventricular arrhythmia, sometimes 24-hour portal you'll miss the bit. So the pickup or sensitivity is very, very low. 24-hour blood pressure monitoring, fairly okay. So you'll be able to see what are the blood pressure at home rather than they come to the hospital, because they tend to have higher blood pressure when they come to see you. Echocardiogram, you could do it, but it doesn't really help much. But the thing that we could help is active passive scan, which help to diagnose orthostatic hypotension. Head-up tilt table test, we are using Italian protocol that could suggest or diagnose syncopal attack, vasovagal syncope, and cardiac sinus massage for diagnosis of cardiac sinus hypersensitivity. Okay, this is the task force machine. What you can see, our patient are lie down on the bed where the bed can be tilted. That's why this is called table test. So, and they are being attached to a computer or device that able to monitor their blood pressure and heart rate beat to beat. So you could monitor every contraction, and you could every rhythm, and continuous monitoring it makes it able for us to see what's happening when you make a patient from lying down position to a stand up position. So you'll be able to see a direct change of the heart in terms of their blood pressure and their heart rate. Because the usual Omra machine, what happened with it, it takes time. So you need it to pump to be able to get a blood pressure result. So unfortunately, when that happened, the blood pressure drop are missed. And you find that majority of the patient, when they come in emergency side, they're having higher blood pressure rather than a drop of blood pressure, because there'll be a reciprocal change. So the blood pressure drop, patient drop down, you brought patient to the hospital. By the time they came to the hospital, the blood pressure is actually high rather than low. So what you can see here, this is what we are seeing on the monitor. You could see the lead 1 and lead 2, and you could see the blood pressure contraction, the systolic and diastolic blood pressure. You could see the heart rate at every beats and what's happening throughout the situation. So when you put patient in a standing position or from a lying to a standing position, you will see a sudden drop, and the change of the heart rate and blood pressure could be seen quite obvious in our patient. So this is the protocol for active or passive stand. Why do we decide active or passive stand? Depends whether the patient could actually stand. So some of our patients could be very frail or have a very poor knee problem or had a history of stroke, so they are not able to stand up as fast as we wanted to do. So then active passive stand will take place, means you actually put the patient and wrap them on the bed, make them stand up. Sometimes if they can stand on their own, we'll encourage them to just stand up and let us see how the blood pressure and heart rate respond when they will be put up a standing position. Head up tilt table test. So this is a bit long. It just takes about 40 minutes to 50 minutes. So patient will put at supine position for 10 minutes to ensure that they are in a resting position. So you could see during rest how their blood pressure is. Then you tilt them up and put them up for 20 minutes to see whether there's any response when you put them in a stress position. If it doesn't show any much change, you tend to induce hypotension event. This is where you put give a gut nitrate spray and you expect the blood pressure will drop. But at the same time, you expect as a physiological change, when the blood pressure drop, you tend to increase your heart rate to ensure good perfusion to the brain. So if the blood pressure drops and your heart rate doesn't work as fast, you then tend to have a low blood pressure and patient tends to collapse of a simple effect. When I talk to my patient, I'll say that this medication is to put you in a stress situation, as if when you are standing up too long, or you are sick, or you're working too hard, you're not sleep, all this induced vasovagal syncope situation. So we are trying to induce and see how your body responds to a hypotension situation. Cardiac sinus massage is quite specific assessment if we consider someone to have cardiac sinus hypersensitivity. So if someone are to tell you that they drop or they fall down when they turn their head to the right or to the left, that might suggest to us there is some sensitivity to their baroreceptor area. So you do a cardiac sinus massage and you see, again, when with this machine, you have the ability to monitor the blood pressure and heart rate as you're doing the event, you're doing it. So you could just massage and you see whether the blood pressure drop. You would expect when you massage or you stimulate your sinus, you would have a blood pressure drop, but it should not be more than 40 millimeters of mercury. So the drop should be doesn't really drop too much to cause you to have such a sudden fall. The how I try and to summarize in terms of different diagnoses and different diagnosis for our patient, as I treat overtreated hypertension or autoset hypotension can be due to overtreated hypertension, dehydration, or sudden blood loss. So if a patient has history of unwell for a week, have not been taking much water, or maybe sometimes patients, quite commonly our end-stage renal patients could have orthostatic hypotension. The blood pressure is high, but because they are actually dehydrated, when they change in terms of posture, the blood pressure change can be very much, tremendously a lot, that lead them to suddenly fall down or collapse. Vasovagal syncope, you try to look for history of triggering issues such as micturition or prolonged standing, generally very unable to cope with crowded places, or it just occur at certain time of the day instead of early morning. As I said just now, cardiac sinus hypersensitivity, it occurs when you turn your head. And for another group of patients that we found quite frequently in our clinic are younger age group patients. They tend to present to us with palpitation and giddiness while they are changed into posture. This group of patients, what happens is when we do tilt table test, active stand, or increase of heart rate, that is more than 30% of their baseline. So if you are someone generally resting, your heart rate would be about 70, maybe 60, probably 80. But what happens when you stand up, it wouldn't increase so much. But for this group of patients, what happens is when they stand out or they change their posture, their heart rate could change tremendously a lot. So from 70, 30% of 70 will make them suddenly change to about 100, 110 beats per minute. And with that stress onto the heart, you see that the blood pressure also would tend to drop because your pressure cannot cope. Then they present with giddy, dizzy, a bit more on palpitation than the older age group. Okay. So this is what we are able to offer in our fall and Syncope clinic. And so far so on, we accept a lot of referral, and we are accepting more referral from younger age group because like POTS and also vasovagal syncope occurs in the younger age group rather than our elderly population. But we are still championing our geriatric patients. So we hope that although blood pressure is an important element, especially in elderly, because we tend to think that generally they have a hypertension, although we don't realize that the hypotension event is very, very common. And overtreated hypertension is very, very common. The recent study that we've shown that almost like 30 to 40% of our patients that come to our clinic, when we actually do this treatment, we tend to have to stop their medication because their blood pressure runs at 120, 110. Although when they go to the emergency or they went to the RUCA or even to our clinic, they tend to show your blood pressure 150, 170. They could be just because they're stressed when they see you. Could be just because they're waited for 2, 3 hours when they see you. And by the time they go home, they relax a bit, their blood pressure drops a little bit more. Changes of weather is a very more reason for them to have like sudden blood pressure drop because they don't drink enough and they fall down. Okay, I think that's it from me. Thank you so much.
Right. Thank you, Prof. Izzati, for the interesting talk on fall and what are the fall and syncope services that we have in UMMC. So sorry for the technical issue just now. Just introduce myself again. I'm Amanda. I'm a geriatric trainee. So as we can see, fall actually can happen in anyone. But of course, indeed, elderlies are more vulnerable. And the impact of fall to them would lead to mortality, morbidity, and also a psychological impact. So fall must not be overlooked. So it's important that we picked up the patients that actually have fall, or even near fall would be a good candidate that we can actually refer to this our service. So with that, I also would like to actually check. Probably there's a question. Any question, please kindly share with us at the question box. So we have one question this morning. Our very first question would be, do you accept referral for young patients with suspected postural hypotension? Yes.
Thank you so much for the question. Yes, we do. That's simple question. Yes, we do. But probably it's slowly getting interest from the other side, from the pediatric sides or from the ENT side. We usually have patient who comes in with syncopal attack. We probably manage them similarly as our pediatric patients. So still investigation, or do some blood tests, so we ensure then when it happens, how it happens, and we do manage them too.
All right. Maybe we can just probably I can just ask a question. For example, if we do have patients that require to be referred to the service, probably is there any particular criteria or prerequisite in an elderly patient who had fall or recurrent fall when referring for evaluation?
Prerequisite, what do you mean?
For example, I think some of them probably will have some injury, or how soon post-operative, where they develop fracture following fall, and how soon can they actually be referred to this service?
Thank you for the question. I think used to be you could get it within 1 or 2 weeks, but more recently, probably within 1 or 2 months, which I think is a sufficient time to come and see to our clinic. As long as they have more than one fall in a year, so 2 falls, or they have injurious falls, frequent falls, or giddiness and dizziness also. Um, I think if we talk about dizziness and giddiness, I will be talking something from the ENT point of view. It is a very difficult thing, or one of the very difficult symptoms for us to diagnose or manage. But if there is any question about it, yes, please do just refer to us. We are located in Menara Selatan, level 7. So you have to go there with either a memo from your referring doctors. We do have a form, but I find that probably the form are not well circulated, so not many are available that have to follow themselves. So a memo itself would be sufficient to, for getting an appointment to our clinic.
All right. We have another question. So, does seizure can be considered as normal in elderly?
Thank you for the question. Very interesting question. Does seizure considered as normal in the elderly? No. I mean, seizure is not normal in any age group, whether it's a febrile seizure or the elderly seizure. But seizure is not normal, although you could consider a fitting episode occurring when you have a low blood pressure. That might happen, but it's not something that you expect to happen frequently. And if someone has seizure, when you name them seizure, means you are kind of telling that it has been frequent enough and you need to treat them with anti-seizure, which is something that we try very hard not to in our elderly population. So, if you find someone falling down with drooling of saliva or incontinence at that point of time, this consider a very significant fall or injurious fall and need to be managed appropriately. It can be like either seizure causing them to fall down or the hypotension itself causing them to have seizure. So sometimes we do a active stand or sleep table test with an EEG to ensure we get appropriate diagnosis before we continue managing this patient. So we do work with the neuropsych. If the patient are like in between, whether this is seizure, whether this is a fall, we could actually do a table test with EEG machine on the go. So we'll see the changes at the same time.
All right. So, due to time constraint, probably our last question: will table test be beneficial for patients who are admitted for loss of consciousness as part of the routine investigation?
It is, I think, if possible, if we could expand, because we're slowly, our clinic, we do have like 4 clinics. We have 2 machines that is working at this point of time. So it'd be very, very beneficial if someone have loss of consciousness, besides having focal or continuous 24-hour BP monitoring. I think a fall or a sleep table test is more appropriate and it has higher sensitivity and specificity, and you'll be able to get diagnosis on the spot rather than for 24-hour focal or BP monitoring. So, but I do realize we probably need to expand if you plan to just take all the referrals. But yes, just refer and we'll see what we can do.
All right. Thank you, Prof. Izzati, for the interesting talk on enlightening us about the service that we have for fall and syncope. So, just would like to share, probably again, today is actually a very special day for all of us because it's the International Day of Older People. We call it IDOP 2023. It's actually a 2-day celebration that we'll be having at PPUM. We'll start off with the opening ceremony itself, starting from today at 9 a.m. at Bangunan Plaza PPUM. So please do come and join us. And tomorrow we have an interesting series of webinar. So it will be starting in the morning as well. So please do join us for this 2-day celebration and we hope to see you there. So with that, I thank Prof. Izzati and everyone for joining us this morning. So I'll hand over to the next team of speakers who will be sharing with us today. Thank you.